Welcome to the latest episode of MQ's Open Minds. And Craig and I this week have fantastic guests. We've got John Torous, and John's a board certified psychiatrist and the director of the Digital Psychiatry Division at the Beth Israel Deaconess Medical Center in Boston. So welcome to the podcast, John. Great to have you.
Thank you so much for having me.
Welcome in.
Yeah, so I'm pretty familiar with your work. You've done some great work over the years, and so I'm really looking forward to get into the sort of nitty-gritty of some of the details of digital health. But what we always try to do in the podcast is maybe take our listeners, our viewers on a journey. So, John, when I was reading up about you, you don't have a straight medical pathway. You went, I think, through electrical engineering and computer sciences. So can you maybe tell us a bit about that journey and how you got to working in mental health?
Yeah, I don't think as you said, thought this was where I was going to end up, but perhaps most journeys, right, don't actually go where we think they're going to end up. It's life takes you in different directions. But I think in essence, I was doing computer sciences and relatively happy with it as a field. I think that what I noticed is it's somewhat isolating to always be in front of your computer, coding to your computer and talking to your computer. Your computer will give you messages, your code isn't working, it is working. So I think I enjoyed the rigor of computer science. I liked what it could do, but I thought in part it was a little bit isolating, was at least my own experience. And of course,
Yeah.
there's many ways that it doesn't have to be isolating. And then almost thought, well, medicine offers, again, perhaps hopefully the same level of rigor. And we can talk about there's differences. Medicine and computer science, this was before AI, so they were even more
Yeah.
far apart. But thinking, is that a field that has an interesting scientific background? You can really do rigor, you can bring evidence, but it's a more of a social game, right? Right? As all of us here and listening know, right? Healthcare takes a lot of people. It's not just physicians, it's not just patients, it's family members, it's nurses, it's social workers, people with lived experience. It's a huge, diverse team. It's a very social enterprise. So I went towards healthcare and went to a US medical school, kind of looking to bring kind of that rigor of the computer science engineering world, but perhaps more the social aspect of what you could do. And I think what's nice, at least about the US medical schools, is you really get to see everything before you have to make up your mind what you want to do. They
Mm-hmm.
let you rotate in surgery, so you can say, what would it be like to wake up very early and be a surgeon and do that? You get to see internal medicine, you get to see pediatrics, you get to see psychiatry as well. And I think there is something to just forcing people to see everything that really gets you to say, what are these fields doing? What do they happen? Because we know there's stereotypes, there's biases, there's misinformation. So it's hard for everyone to know what is psychiatry. It's hard to know what is psychology. We're not talking about today, but I think in some ways having people rotate and see all of them is a wonderful thing. Because in my case, it really opened my eyes to how much better people could get in psychiatry. Because I think I had just come off internal medicine and it was wonderful seeing people getting better with some very chronic illnesses, with heart failure, battling cancers. But what was interesting is being on the psychiatry ward, you would see people leave and they were great. Again, they had follow-up care to do, but they
Yeah.
came in, they were not doing as well, and they would leave after 1 or 2 weeks, and you could barely recognize the person. Well, physically, you could recognize them, but then it was a whole new person. They had a new outlook, they had new goals, they had more connections built, they had new purpose. And there was something very inspiring in seeing that there really can be these truly transformative recoveries.
Mm-hmm.
That again, I think our colleagues in medicine and surgery are working very hard, and we have to give them full respect. It's very hard to be a GP or family doctor, but I think sometimes they may not get the reward of seeing these amazing recoveries that we can get for people who come to and get mental health services. So in some ways, picking psychiatry was really driven by just seeing the potential of the
Mm.
field. And again, I sound like an old person. This is before COVID. This was before AI. Can you believe such a time? There were dinosaurs roaming the earth. There were volcanoes.
Well, we
It
can
was
just
just
about remember before COVID, I think, but remembering before AI, that's a stretch.
it's exactly, but it was just you could tell even then there was potential to also bring innovation to the field too, to take what we could see happening when people got the right care and say, could that be expanded to more people?
Yeah.
Could we kind of bring that wonderful success to everyone? Because we know there's not that many inpatient wards. There's only so many beds. and we don't have to go to numbers. Everyone here knows there's huge demand for mental health. And
Yeah.
I like to say every country is a low income, low middle income country when it comes to mental health acts. It doesn't matter if I'm calling you from the US, you guys are in the UK, if it's Canada, Europe, we all don't have enough resources for mental health.
Well, hopefully remember, because I think I think you have a paper, I think it's just either it's in press or coming out, I think in Nature Mental Health, looking at, I think, the digital divide in context of, and we can maybe come back to that,
Yeah.
in number of beds and so on. But just to sort of circle back a second, and so you get it. So you obviously you did your computer science, obviously really inspired into going into medicine. So then when you get into psychiatry, so how did the move then go from psychiatry in general to, obviously, because what you're most known for is the sort of digital stuff?
Yeah.
Is that just a fortuitous moment, or was it by design?
No, I think it was as one of the junior doctors, I was rotating through different clinical services here in the Boston hospital, seeing a lot of patients. And I think it was around 2013, 14, so perhaps a decade or more ago since we're recording this. But a lot of patients, when you would meet with them and say what's happening, one patient would actually show me a text message log and say, here, you can see what's happening. And there was, say, a breakup happening. And there were other cases where we're trying to figure out, was someone having sleep difficulty and what was happening? Did that trigger it? And they said, here, look at my phone. You can see my sleep log. So patients actually were trying to help me as a junior clinician understand what was happening and see their experience, and said, here, I have this data on my phone. Would this be useful? Will it help us get to the bottom of the case together?
Mm-hmm.
And I brought that to my colleagues and I said, these phones have a lot of, our patients are ahead of us.
Yeah.
In a good way. They're seeing these amazing use cases. We had patients with schizophrenia who were using their phones to play music to block voices. Again, this has happened for a long time, but they said, this is great. I have my headphones, I can pull them out. We had other people. And so we saw, I think by seeing these wonderful cases, I think, quickly saw it as a field, perhaps psychiatry was very far behind of the innovation that patients were leading in finding these remarkable use cases. And when I brought this initially to my colleagues, again, this is 2013, 2014, one of the initial responses, well, patients with more serious mental illness, which for the sake we'll call schizophrenia, bipolar, and major depressive disorder, I said, well, those patients may not have phones, and the phones may make them paranoid. And I said, that's not true. I said, I'm working with these people every day.
Yeah.
They're using their phones in interesting ways. They have phones that are fancier than my phone. Some patients politely teased me that my phone was very old and made me run out and get a new phone so I could have one too.
That's
But
peer pressure for you.
it was peer pressure. But what that started is we did a survey, and it was a very simple survey. We just said, do you have a phone? If so, do you use apps? What type of apps do you use? What are your concerns? What are your fears? What are your hopes? What is good? And the results of that survey, again, looking back, right, it was, of course, people had phones. Of course, they were thrilled to use them as part of the recovery. Of course, they were worried about privacy. Of course, they're worried where their data went. These issues are perhaps universal, you could say. But I think that really seeing that difference of what the field was seeing and what just people on the ground, not even patients, were doing, I think that was very energizing to say, this is an amazing area that we need to move really quickly in. And this is something where if we do the right partnerships with patients and we're on the ground truly co-developing, building things with people, we can do a lot quickly because people are calling for it. So I think you're seeing it was, again, inspired by working with people on the ground and seeing what they were doing and moving it forward. And that really did kick off. Again, it's expanded to work. It's gone in different directions, but I think it does all start from there of people saying, look, I'm doing this already. If I'm doing it, do you want to use it to maybe help me get better?
Yeah. So that's really fascinating. So then, so you did a formal, was it a formal survey you did of a patient population, and then was that published? And then what year was this? Is this 2015, 16, something like that?
I think it was published in 2014. So it was
14,
done at
yeah.
a couple sites. It was done with a psychiatrist called Stephen Chan, who was then at UC Davis. It was done with a psychiatrist also at LSU in Louisiana. I did the Boston site, and I think someone called Jake Brennan's did Wisconsin. So we had 4 different sites.
Yeah.
And it came out, so it was nice. We had 4 different sites, 4 different populations, and you kind of just saw again the same signal of people saying, of course we want to use it. So it was a nice way to kind of translate what we're seeing into a way that the field could understand, to say, Here's a paper." And I think those are kind of the most interesting moments, right? When you can see something, the patients see it, everyone sees it, and you can kind of then help steer the field to really catch up. I think it'd be wrong to say it's innovation, because the innovation was there.
Yeah.
And one of our earliest papers, we co-wrote, our team, a case report of a person with schizophrenia. And I'll share the case because, again, we wrote it as a paper, but he was on antipsychotic medicine. And as we know, sometimes with schizophrenia, you can have auditory hallucinations, and you can have a lot of them. And he was having more auditory hallucinations each day, and there was a need to go up on the medicine. And as a very smart, informed person, he said, "Well, there's side effects if I go up on the medicine," which is perfectly true. He said, "Look, if I'm going to increase the dose of this medicine, I want to know it's effective, right? I want to understand the risk benefit. I know what the side effects are. I've read about it. We've talked about it. I think the benefits are it could help with these auditory hallucinations, but how do I really know it's helping with auditory hallucinations?" So on his own accord, he had a system where he was basically counting how many auditory hallucinations per day, plotting it, and then over time with different changes of the medication. And he was able to show a very nice curve. Whereas the medication went up, the number of auditory hallucinations went down. He brought it to me and said, "I think this is good for me. That this risk benefit makes sense for me in my context." He's not telling other people what to do.
Yeah. Yeah.
It was a very nice case of where there was that great innovation. So again, we said, look, this is real innovation. We should put this into the medical literature so people can see it and be inspired and learn from it. But again, I think all credit goes to, again, this person. And I think that's where we have to take a humble approach and say, look, there's really good ideas out there. People with lived experience are finding amazing solutions of how to use technology. And I think, again, we'll perhaps jump to it later, but people are probably doing amazing things with artificial intelligence right now that we're going to understand. And I hope it's not 2 years later we call that innovation. And someone says, I was doing that.
Yeah.
I was doing that in 2024, and we're having a podcast in 2034 going, oh no.
So that obviously, yeah, I think what's great about that is obviously it's driven by the patient experience, the individual with lived experience, and driving that forward that way. So let's think about, so for the listener here who's unclear about to the extent to which the digital health innovation or whatever interventions have grown.
Yeah.
So where do you see our big successes, and what's our evidence? What's the evidence tell us? Maybe for a range of mental health problems, obviously, because you've talked about schizophrenia, psychosis, through to obviously anxiety, depression.
Yeah. We're at a very interesting time in these digital mental health innovation. These digital mental health apps and just interventions. Our team curates a database. It's called mindapps.org, mindapps.org, mindapps.org. It's completely free. It's sponsored by a gift from the Argosy Foundation. And what mindapps.org does is it indexes about between 600 to 750 mental health apps. And what we do is we let you, as the person with the illness, the clinician, the family member, filter them by cost, privacy, evidence, engagement, condition. And I think we have 105 filters. So if you can create a search and say, show me all the apps that do CBT and use a chatbot and are free and are made by academics and have a privacy policy, we'll probably say that doesn't exist. But the idea is you can make as many queries as you want. You could make trillions of queries. And the idea of MindApps was to put out this database that you could easily search to say, what are the tools that exist today I may want to use? And every app on there is $10 or less. You can download it today. We don't want it to be academic things that you can't really use, or you have to have a passcode, or you have to be part of a very special club to use it. These are things that you can go to today and you can download and try to use it. And I think by curating this mindapps.org database for many years, we've really got a good sense of what's available directly to people, which is sometimes very different than what is happening in the research literature and things that we read and see. And I think what we're seeing is there's a lot of duplication in these apps that are available. There's, dare I say, too many mindfulness apps. There's too many mood tracking apps. They're all roughly doing the same thing. So I always at least
what's the evidence say for it? So you talked now, you've got whatever 105 different filters.
Yeah.
But I suppose, to my mind, number one has to be, do they work? And do they cause harm? So what I mean, the field,
Yeah.
my reading of the field, certainly from the suicide literature, is we've made a little progress. There's some evidence growing, but we
Yeah.
haven't. We're still a long way to go. I know there's better evidence, I
Yeah.
think, for other conditions. But so, what's your sense of it, John?
So my sense is for most of the apps, the challenge of them is they get very low uptake and real world engagement
Yeah,
in
yeah,
use, right? So it's like with the holidays coming up, if we give everyone listening a free gym membership, this is amazing. MQ is going to give everyone a 1 year pass to the gym. You can go as many times as you want.
very generous of MQ, obviously.
Very generous of MQ. We won't hold it to it. But you can imagine, right? Just again, uh, take your own experience. You may go once or twice on
Yeah,
average, but you may not return. Right, right. And so just the fact that we have it accessible doesn't mean that it's used. And if you think about any medicine, if you don't take it, it's not effective. Any therapy, if you don't show up at therapy, it's not effective. Any lifestyle intervention or diet, if you don't do it, it's not effective. So I think in part that the scalability of the apps is so exciting that we can do these things. But the cost is we have to find a way to make it really engaging. And we've seen gamification alone does
yeah,
not solve this. Paying people to use it does not solve it. It probably comes back to, again, we'll go back to our gym analogy. A gym buddy has been shown to be pretty effective at getting people out into the gym. So you may need,
And what's gym buddy for those who don't know?
yeah, so a gym buddy would be someone you go with, right? They kind of say it's art, you go to the gym together with a friend or a colleague, and you do it as a social activity. And so it could be that we need kind of a new workforce of, it's what our team is called peer digital navigators. People with lived experience become digital navigators. They're able to kind of help you pick the app you want to use. They're able to help you stay engaged. They check in with you. They're not acting like clinicians. They're just helping you go through the program, right? Just like a coach at a gym can help you do weights. They're not acting as your doctor. They can help you find a good regimen. So there could be a world where we say the peer digital navigator brings amazing lived experience. They bring amazing knowledge of how to search a database like Mind Apps. They bring amazing digital literacy to help people who aren't ready to use apps learn to build those foundational skills, and they help you engage it. So maybe, again, if you're my digital navigator, you'd call and say, "Hey, John, I noticed you haven't engaged in a couple of days. Is everything okay? Do you want to do a module together?" And that perhaps could really, from the evidence I've seen, is sometimes just adding that human can double the efficacy of an app. So
Yeah,
you could take an app that is working at whatever efficacy level, and you can get a times 2 benefit. That's remarkable. Like,
yeah,
where else in healthcare can you double the efficacy or the potential of your treatment? And I do think if we haven't seen the psychiatry field, right, probably is who will be digital navigators? Will it be psychiatrists? They may have a lot on their plate. Will it be psychologists? They maybe have a lot on their plate. It could be a wonderful new role for the peer community to
yeah,
kind of step up, and I don't say control in a bad way, but really become the experts at it. Say this is the amazing thing that the peer community can do. And they actually begin to lead this whole new field
yeah,
of digital mental health and say the second generation is built with a peer digital navigator. We're so excited. There's all those self-help tools. And of course, if some people can use on their own, that's wonderful. We're not saying people shouldn't try on their own. Of course you can, but if we think for most people we can make it twice as effective and probably more enjoyable to do it,
that'd be incredible.
that's
Yeah,
wonderful.
yeah. But I mean, in some sense, it's not a new role because we've been doing it in physical health. I mean, so you're
Yeah.
obviously health coaches in physical health, so it's just tailoring it to mental health. So then, so John, thus far though, have people? What's the evidence say? Have you and your colleagues and others across the world been testing this?
Yes, so we've been testing different models of digital navigators, and there's a free paper in Lancet Digital Health, I think from late 2023 or early 2024, that reviews the role of digital navigators in different efforts towards it. But I think if you look at any kind of modern digital mental health effort, you'll see that the digital navigator is finding their way in. They may not call it a digital navigator, they
Yeah,
may call it a research assistant, a coach, an assistant, but there's always someone probably sometimes behind the scenes. They're not given the full credit and due. But for a lot of the digital health interventions that seem more effective, you're seeing the human creep back in. And I'm saying, why should a human creep back in? We should celebrate this. This is a role. These are perhaps the thing, right, that drove me to medicine is wanting it to be social. These are going to be social technical systems, and we should embrace that and say this is how they work and not keep trying to abstract a person away and say, no, 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 no. There's no human involved. And we'll see again where AI takes us
Well, that's good. That was
journey.
exactly my next question, which
Yeah.
was taking some of those to what I mean. There's obviously a huge drive to try and
Yeah.
replace with AI. And I suppose in some senses that the example you gave earlier about somebody, oh, if you're not using the app, it's somebody checking in to say, are you
Yeah.
doing okay? Why aren't you? But there's no reason why that couldn't be.
No, exactly. And if we look back at history, right, we had self-help books in the 70s and 80s. We had CD-ROMs in the early 90s.
Yeah,
Then we
see,
had
you're on, of course. Yeah.
we had websites in the 2000s. We had apps in the 2010s. Now we have we've had all these resources in different modalities. So I think AI will appeal to some people, and that's fantastic. They can thrive with it. They can get better. We'll celebrate that win. But I think we're still going to need a little bit more than AI. And again, for some people, it's going to be enough. But I think just the trend of history is pushing that we should probably think of a different approach maybe to it. And again, use AI synergistically.
Yeah.
Use the app synergistically. Let's not repeat what we did in the 70s, 80s, 90s, 2010s. It gets a little bit boring, frankly, right? To kind of see the same hype cycle come and go. And I think it doesn't even help these companies, right? I think companies have a very important role in the space. They build wonderful things, but we've seen a lot of investment in the digital mental health space. I don't think we've seen a lot of companies come out wealthier. I think we've seen a lot of high profile bankruptcies, right? I think Pear Therapeutics was valued in the billions of dollars at one point.
Wow. And
And
what did they give us an example of some of the apps that they developed?
yeah, so they were developing apps that even got FDA clearance for substance abuse. They were developing apps for schizophrenia. They were developing apps around sleep. But again, I think I'm not an expert on exactly what happened to them. And again, I'll let readers look up Pear Therapeutics.
Yeah.
But the point is, industry could also learn to try to do things differently too. And I think what we're saying, having a digital navigator means you're not infinitely scalable. Like one piece of software technically could reach billions of people, but it hasn't, right? And I think we have to say, look, having a digital navigator is a person. The software is still going to be incredibly scalable.
Mhm.
You're going to reach new audiences with a digital navigator because you're going to teach digital literacy. You're going to help people who don't even know to ask for these things. Like we're almost assuming, right, that everyone is asking for, interested in it. A lot of people don't realize their phone can do these things. They don't realize AI could help with mental health.
Yeah.
And so that digital navigator can really help expand access and equity while onboarding people and keeping them engaged. And again, I just think that's a different approach, but I think that's going to really be a win for everyone in the space.
Yeah. So okay, so that brings us on then, I think, to when you're talking about the reach and is it the digital divide of the whole issue of
Yeah.
digital divide, and both within countries as well as across the world. And I think I mentioned earlier that you have a paper coming out looking at this. You looked at, I think this is in the US, you looked at lots of data from the US, looked at a number of health outcomes. So you may tell us what you found there and sort of the wider implications on how we can genuinely tackle the digital divide rather than increasing the divide.
Yeah. It gets back to the point I think that we discussed earlier, right? That a lot of us have phones and technology. We know how to use it. We love it. Sometimes we hate it, but we have these devices. But there are, right, some people have not learned how to download apps. Some people don't understand how to switch between Wi-Fi and data plan. Some
Yeah.
people have problems with the accessibility. They don't know how to change the font size. Some people don't know how to safely filter out, say, fake news or content that comes up when they watch YouTube. And so what we've learned in working with people for almost a decade in this field is that people want help. And sometimes they don't even know to ask for help. So we've run for many years these digital literacy groups where we go into different community mental health centers. We have curriculum, slides, handouts, and we start with the basics. We say, here's a phone. We're very sorry that the home button that you could push is gone, but we're going to teach you how to swipe. And we're going to teach you how to put your phone to low power mode. And we're going to teach you
Yeah.
the basics. And we build up from that of how to build a wellness toolkit, how to put a safety plan in your phone. And we've learned everyone can learn these digital literacy skills. It doesn't matter if you have an illness like schizophrenia, if you're young, some people don't know it, if you're older. And when you teach people how to use their phone like this, you're really giving them a functional skill to use, say in 2025 and onwards, right? I've had patients, my favorite story is a patient said, I need to learn how to use my phone. I said, oh, that's wonderful. You want to track your medications? And they said, no, 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 no. I want to order a burrito, and the burrito restaurant will only let me order a burrito if I use the app. And I need to learn these apps. But
Yeah,
but that is unfortunately, right, for better or worse, that's the world we're going towards. There's a
yeah,
lot of, and if we're not offering concomitant digital literacy with any digital effort, I think we are going to make a world of people that can access it and people that can't. And I do think we have seen far too little focus on digital literacy, especially for mental health. I think we've seen a lot of great work on building apps, on building AI, on building programs, but I'll say from doing this, it's been very hard even to get support for digital literacy work sometimes. People assume, well, someone else will do that, right? The hospital will do it, the doctor will do it, the family will do it, the state will do it. So it kind of everyone keeps passing it around. And I am happy that's why our team has built a lot of resources that we share. Again, and it works really well. We've tested it to the extent that you can test educational interventions and people love it. And I will say it's not just the stereotype that older adults need training. There's a lot of
yeah,
different reasons that people want help. And just to dispel one other kind of stereotype, if you look at digital health studies, older adults are the ones that engage the most. It's
yeah,
the younger people who get too many notifications and they find it actually harder in some ways to use the apps. So we do have to step back and kind of not say one population, of course, needs more help. Or another example, like there's no evidence that smartphones make people with psychotic disorders paranoid or delusional. People are people. They use technology in this modern
yeah.
world.
So then moving on. So then but okay, so that's looking at sort of diversity within maybe high income countries, right? So
Yeah.
what's it like? What's going on globally in the context? Is the digital divide worse in low and middle income countries? What's
Yeah.
the chance? Because I know there's obviously innovations in terms of providing data packages and for free and all that sort of stuff. So where are we at with that?
So I think what we're seeing is in most countries, younger people seem to have access to these devices. So the age, I think we see less ownership overall, say compared to high income countries, but young people seem to find a way to have the devices. What we begin to see, though, is sometimes phones are shared amongst families or communities. And of course, that has different implications of privacy. If you're collecting digital signals from the phone, you may have to think carefully what those signals mean. Is it reflecting a shared family unit? I think, though, we're overall just rapidly seeing that phones are getting really cheap. More and more people have them. And each year, you can kind of look up national data from groups like Pew. It's getting to the point where it's close to saturation. Like, when we run research studies, we often will offer people a free phone if they don't have a phone or one that works. We rarely have to give out those phones in this day and age. And we do research in different countries. We do research in India, and people have devices. So in some ways, I think we can say Silicon Valley and Moore's Law has done a good job of making these devices more accessible.
Yeah, yeah,
But it's a digital literacy, right, that's not improving, right? We're not seeing kind of that exponential improvement each year where the devices get cheaper. And I think it's just because the digital literacy is a little bit harder to visualize, right? We can all kind of imagine our mind not having a phone, being stranded and not having, I mean, just imagine just going through a city without your phone. But it's a
yeah.
little harder to kind of say, well, what would it mean not to have those digital literacy skills? I think just because we all intuitively have them, that's why you're probably listening to this podcast, right? As our listener, you were able to get to this step, and so you're well past the digital divide. You're on one of the camps.
So what I'm hearing then is, or am I interpreting it, which is that the single biggest challenge to the success of digital health interventions is the digital literacy. Because you think that there's enough evidence out there. We think of interventions which work, but often there's not uptake, and often that uptake will be
Yeah.
in part to do with the navigators. But then there's this digital literacy thing is a huge challenge.
I'll say yes and clarify that. I think the foundation has to be digital literacy. So that is the first and foremost challenge at
Yeah,
this point. If it's not equitable, who cares?
yeah,
Again, it has to be engaging. But I think one thing that we've seen in the early evidence for a lot of these apps is oftentimes the app will say, well, we're very effective. And you go, compared to what? And they go, compared to nothing.
Yeah.
You go, nothing? And they go, yes, there's little limited access to mental health care, so nothing is an appropriate control group. And you go, what about playing Tetris on your phone? Everyone has access to Tetris. What about tracking your mood? Everyone can track your mood on your phone. There's free apps for that. And what happens when you begin to add in what we'll call a digital placebo, right? An app that's not the active ingredient that kind of takes into effect you're using a smartphone, you're engaging digitally. A lot of the apps that claim to be effective look a lot less effective when you kind of do, I won't even call it
Active
better
control.
science. You do normal science, right? You kind of compare apples to apples. So if we kind of say, well, if we had a foundation in digital literacy, and we found apps that we again felt were safe and effective, that respected your privacy. And the apps, right, could beat a digital placebo. They're better than Tetris. This is a low bar, but we're not
Yeah.
demanding too much. And then again, they were engaging. I think that's what we want to find. And we've kind of codified some of this in the American Psychiatric Association's app evaluation framework.
Hmm.
We have those layers. It says look for things, make sure equity is there, then make sure it's safe, your data's okay, make sure it's effective, as we talked about, it hopefully beats Tetris, and then make sure it's engaging and it's useful. So we've had these principles out there for some time, and I think it also shows you we know that mental health is it's these are complex illnesses. It's challenging actually to build something that's going to be effective for everyone, and I think so. We've
Well, no,
seen
no treatment is it? So
yeah, exactly. There is no, there's not a single digital panacea or kind of magic silver bullet that's going to fix everything. And I think building those systems with that in mind doesn't really solve anything, right? Because in the end, it just leads to the people who invested money in the systems lose their money, the patients who are getting care don't get care. It doesn't lead to as much. So I think if we take a more realistic view and say, look, we have a lot of things to figure out at this point. We need to figure out the equity. We need to really figure out how do we keep people's data safe and secure. Technically,
yeah.
we can do it. That's not a technical issue, but what are the rules in place to stop misuse of people's data? Why is it that some of these apps are not beating a digital placebo in Tetris or mood tracking? What can we learn from that to make
Yeah.
the next
Yeah.
generation better? And how do we make these engaging? How do we match you to the right coach? Or can maybe AI can do it? But you can see there's some very fundamental questions, and these are answerable questions, right? These are not saying we need to build a colony on Venus by 2026, right? These are things that we can do as a community, but it does take a focus away because notice we're not talking about a product. We're not here saying app X is the best app,
Yeah.
and
Yeah.
if we do
Yeah.
it, what we're talking about kind of what's behind all these apps, and that's a different discussion where so much today it says the product did X, Y, and Z. We need to say, no, 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 no. We'll get to products. And we want there to be products. We encourage it, but we've got to have these fundamentals straight because else we're all going to get lost. And I think that's why, again, this is coming out right in basically 2025. What we're not seeing, I don't think anyone would realistically claim that apps have transformed mental health care, despite being around for almost 15 years.
Yeah.
And everyone would say, but they should have. There's potential. And I think where we got lost is we've again focused a lot on products and not as much on the core issues we talked about. And from those
So but
products will
it's just trying to
emerge.
have no. What are the active ingredients? That's what it's. I mean, the same as you do in any other intervention.
Yes.
What are the active ingredients? What are the barriers to uptake? I mean, it's looking at and combining active ingredients with a process evaluation stuff. And I suppose maybe that we haven't done enough of that
Yes.
yet. And but
So
you're saying you're optimistic though.
exactly. We can solve those, and those active ingredients have to be shared freely, right? We can't have
Yes. Yeah.
one research team, one company, one people saying we have this active ingredient. If you have 10,000 chefs in the kitchen or 10,000 mental health apps all doing different things, it makes sense. You almost have a Tower of Babel, and you're not able to make that. You're not able to let the scientific process work, right? And in
Yeah.
some ways, that just delays the potential and the amazing
Yeah.
things that we know can come from this technology.
You're talking a lot about like literacy, like digital literacy. But in terms of, have you, from a patient perspective, have you had any pushback about these apps? Anyone that said that actually we don't, because I know you're talking about engagement being lower than what should be, and how do we address those?
I think we've definitely had people say, I don't want to use apps. I don't think they'll be useful. And that's wonderful. I think what we've seen too is when we tell people this will be part of your care to augment as an adjunct. It's not replacing your care, it's not taking anything away. It's something you can do between sessions. It's something that can help bring more information you want to share with the clinician. It reinforces what you're doing. I think then people get excited. In our work, we always share back and visualize what we learn from people, from say if we're collecting information on sleep or steps. And people are very excited to see their own data visualized. I think what happens is we can collect all this stuff, but we don't really put a lot of attention into how we share it back. And there's not, we're still learning as a field, right? We've never shared back real-time sleep and step information and screen time information with people. But I think it can be done in a way that people want to use. But of course, like any tool, right? I could go to my GP and say, I don't want to do a blood test, and that's fine. That's my right. And I think keeping it in that context, it's an extra tool. Sometimes it's useful, sometimes it's not useful. And if you don't want to do it, you don't have to do it. It is important and critical.
Okay, no, that's a really important point. Okay, so with two quick questions, and then I have one last unrelated question.
Yeah.
John. So first one is, I'll tell you what the two questions are because they're sort of related. One is, can you tell us about something you're really excited about that you're doing in your lab at the minute, which we haven't discussed yet? And then the second one is, if MQ or some other funder said, here's an unlimited pot of money, what would you say is your number one research question we want to address?
So I think one thing we're doing in our lab that's very exciting is we're using digital phenotyping in a research study to look at how young people use social media. Because again, we know that for some people, social media may not be helpful to their mental health. For some people, it can have a lot of benefits. MQ put out a wonderful report very recently on this. And for some people, it makes no difference. We don't know who it's going to impact in what direction, but I think we can use the phone to understand, one, actually how long people are on social media. You don't have to try to remember, was I on Facebook or Instagram 2 weeks ago for how long?
Yeah.
So the phone can record that. It can record how is sleep going? How is mood going? How are step counts going? In the study, we ask people to voluntarily, if they can, reduce social media impact. And we can say, do the digital signals in your mental health change when you reduce it? So I think we can finally bring new information and new data and new insights into what is the impact of stopping social media. Does it lead to different changes we can learn from digital phenotyping? So we're very excited to learn about that in young people. I think you both touched on it. I think if a group like MQ could help us understand some of the active ingredients in how these technologies work, I think that would be a tremendous service to, again, everyone in the field, right? Every single stakeholder, because building the next generation of apps based on active ingredients and having, again, a cookbook of recipes is going to be really important in telling every person, you actually have to almost build your own kitchen at this point to play in this space, right? It's not, you don't even have the recipe. You have to build your own oven. You have to experiment with recipes. It's really a lot of work. And there's a lot of redundancy. I would almost write a book called Duplication in the Digital Age of just all these things that are just being duplicated for no reason.
Yeah.
And I think that would be a huge service.
Yeah, and I suppose it's also maybe just taking a broader transdiagnostic approach of looking at, well, I mean, that we link into sort of the common ingredients idea. Okay, so John, we're almost at an end. So we're always trying to end with a sort of an unrelated question, which gives a bit of insight into your thinking beyond your immediate topics. So the question to end with is, so if you had the opportunity to write a book in the morning, can be on academic stuff or it could be unrelated, what would the book be on and why?
Yeah, maybe I'll keep it non-academic related because I think clearly I would write one around this topic. I think it would be interesting to write a book on British railway sleeper trains and what exists today. So even to look at, we have the Caledonian Sleeper that probably could go up to you, but what else used to exist? What exists, and why did sleeper trains disappear, and are they coming back?
I was not expecting that. So hold on, are you a fan of the sleeper train?
I have not been on the Caledonian Sleeper.
Oh, you haven't been on it? Oh, it's magnificent.
No, but I've seen it.
I've always wanted to go on one.
Yeah. It's really good, actually. You know, Alan Cummings, who's a Scottish actor. He's been in lots of things in the US as well. He is just, you would love this documentary. He's just done this documentary series on one of it's the Scotsman, what's it called? The Royal Scotsman train, which is a sleeper train which goes up and down. But it's also, I learned a lot from it, but there's a lot of that in the history of the sleeper trains and other trains. So Well,
Sounds like my work is done.
Yeah, you're well, exactly. Well, on that note, John, no, thanks so much because I really had, I suppose, like the tone of it's an optimistic tone, but recognizing that the realism within the evidence, and but your groups and others are really leading the way in this regard. So, there's lots of details on your website. Do you want to give your website details, John? Because I see you also can take part in studies there as well.
Yeah, it's digitalpsych.org, and the app database is mindapps.org. So digitalpsych.org and mindapps.org.
So, John, this release, so thank you on behalf of Craig and I. That was a really fascinating discussion, and look forward to seeing how things progress. And hopefully, we will have this cookbook of active ingredients in the near future. So, thanks a million.
Thank you both, and thank you to MQ. Bye.
Thanks.